Good evening, everyone. My topic is to evaluate the efficacy and safety of adalimumab in patients with non-infectious uveitis. TNF-alpha is a pro-inflammatory cytokine which activates cytokine-driven inflammatory processes, and high levels are seen in aqueous humor during active uveitis. Adalimumab is a humanized recombinant monoclonal anti-TNF antibody. It is well tolerated due to low immunogenicity and is effective in infliximab intolerant and refractory uveitis. Aim of my study is to study efficacy and response of adalimumab in achieving remission or inactivity in patients with non-infectious uveitis and to evaluate side effects of adalimumab during the course of treatment. It is a retrospective observational study done from January 2015 to April 2025 using the electronic records of 37 eyes of 20 patients of non-infectious uveitis treated with adalimumab at Contrast Eye Hospital, Calicut. Coming to definitions, remission is no sign of inflammation for 3 months after cessation of systemic immunomodulating therapy. Inactive disease is no sign of inflammation for 3 months during treatment with systemic immunomodulating therapy, including systemic corticosteroids. And relapse is active inflammation after inactivity for at least 3 months. Successful tapering of systemic corticosteroids is taken as 10 mg of less of prednisolone per day according to some criteria. Primary outcome was effectiveness of adalimumab indicated by patients achieving inactive disease, remission or relapse-free period. Secondary outcome was reason for discontinuation, including side effects. Inclusion criteria was non-infectious uveitis treated with adalimumab and follow-up of minimum 3 months, and exclusion criteria was inadequate documentation and follow-up less than 3 months. Statistical analysis was performed using SPSS 22.0 and results. Analysis of 37 eyes of 20 patients from January 2015 to April 2025 was done. Relevant ocular and laboratory investigations were done wherever required. The mean follow-up period was 13 plus minus 9.50 months. Demographic characteristics: total patients were 20, including 11 females and 9 males, which was comparable. Pediatric cases were 60%, and the median age was 15 plus minus 15 years, and bilateral involvement was seen in 17 patients. Etiology included BKH, IRWAN, Behçet's disease, juvenile idiopathic arthritis, sarcoidosis, and idiopathic panuveitis. Efficacy measures: remission inactive disease was achieved in 14 patients, which amounted to 70%. Steroid-free status in 15 patients. Recurrence while on adalimumab was seen in 5 patients. Ongoing activity in 6 patients. The mean treatment period in patients who achieved remission or inactivity was 14.57 plus minus 9.69 months. Concurrent therapy of adalimumab was done including methotrexate, mycophenolate mofetil, and steroids in various combinations. Visual acuity analysis showed improved visual acuity in 26 eyes amounting to 70.3%, and significant visual improvement was seen in 20 eyes. Complications. Complications were majorly attributed to uncontrolled uveitis over time rather than to adalimumab itself. Ocular complications of posterior subcapsular cataract, band-shaped keratopathy, cystoid macular edema, and epiretinal membrane were seen. Surgical interventions for CME with PST and Ozurdex injections were given in 1 and 2 eyes, cataract surgery in 3 eyes, and combined surgery with cataract vitrectomy and Ozurdex injection in 1 eye was done. Anti-glaucoma medications were continued in 3 eyes. Treatment discontinuation in 1 patient was due to tuberculosis development. Patient decision to discontinue in 3 patients and loss to follow-up in 3 patients. No systemic side effects of adalimumab were reported except for TB in 1 eye, 1 patient. Primary efficacy endpoints of remission and inactivity were achieved in 70%, steroid-sparing effect in 75%, and visual acuity improvement in 70.3%. Discussion. Adalimumab is well tolerated in majority of patients and was continued for as long as 3.5 years in our study. 60% of our patients were of pediatric age group. Visual acuity in our study had improved in 70.3% of eyes, and the loss of vision was attributed to uncontrolled uveitis over time. Remission and inactive disease achieved in our study was 70%, which was comparable by a study by Nida Khan et al., which was 79.3%. Visual 3 study showed sustained control of uveitis with adalimumab, and Sycamore study in JIA showed effective control of uveitis in 56% with adalimumab that did not respond to methotrexate alone. Now, TB risk with TNF-alpha antagonists were studied by Zhang Z et al. With this meta-analysis of 29 RCTs, which showed increased risk with odds ratio of 1.94. In our study also, 1 patient had developed TB and adalimumab was stopped in that patient and ATT was started. Now, contracting TB's risk was higher when adalimumab was used in combination with other immunosuppressive agents versus monotherapy. Two patients who had stopped adalimumab on their own developed recurrence and they were started on methotrexate. Laura M. Urelings showed that steroids and DMRDs, in addition to adalimumab, could prevent the formation of adalimumab antibodies, which can lead to reinstatement failure. Anti-TNF therapy that could worsen demyelinating diseases were reported. No such case was seen in our study. And affordability of adalimumab India is definitely a challenge. Limitations, small sample size, and further follow-up period to assess long-term effects of adalimumab is needed. Conclusion, adalimumab is well tolerated, safe and effective in treatment of non-infectious uveitis with inadequate response to other immunosuppressive therapy by achieving remission or inactivity, low recurrence rate, and improvement in visual acuity. Especially, it is safe in pediatric population. These are my references. Thank you.
Check. This drug is already approved for FDA for all forms of uveitis.
Yes, sir.
So what is the new information you are giving in this paper?
This is
Because this is the result in all the trials also. So what is new in this paper?
we are especially studying in pediatric age groups.
But already there is one publication which says 56%
Yes, sir.
is doing well with this. So almost 60 and 56 doesn't matter. So anything new in this research?
New in the sense we can start this earlier, sir, before starting any other, rather than trying on with the other immunosuppressive agents itself. That could give a better option.
So, other than the one patient who developed tuberculosis, did you have to change the drug or add some other drug in any of your patients?
In between, they had recurrences, sir, when the patients were on adalimumab itself, and those patients were already steroid free. Then, in those patients, again, steroids and maybe methotrexate or MMF, one of them had to be added.
But you didn't have to withdraw adalimumab at any
No,
stage
we
and
didn't
replace
withdraw
it with.
adalimumab, sir.
Okay, thank you.